This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
DPC allows me to be the doc that I always wanted to be. I feel like patient trust is key. And the only way you can do that is with care and time, and direct primary care gives me the independence to do just that, to develop a really good, solid doctor-patient relationship.
This is Rob Rosborough of Township Health DPC in Silverton, Oregon. This is my DPC story.
Dr. Rob Rosborough is a board-certified family physician with 25 years' experience practicing in the Silverton, Mount Angel, and Molalla communities, caring for infants through elders. Dr. Rob is a graduate of the University of Oregon, Oregon Health Sciences University, and University of Minnesota Duluth Family Practice Residency Program. He started practicing in Silverton and Molalla in 1996. He is board certified by the NBPAS and a 30-year member of the American Academy of Family Practice. Since starting Township Health DPC, he has presented at DPC national conferences, became a founding member of the DPC Alliance, and is currently on the DPC Alliance Advisory Board. Welcome to the podcast, Dr. Rosborough.
Hey, thanks for having me. It's awesome. Great to be here.
So I haven't seen you in person since 2019, I think, and it's been too long. So I hope
it's been way too long.
Yeah,
I can't believe it's been that long.
I know.
The last 2 years have been bizarro world.
Yeah, absolutely. So on that note, I want to turn to the world that you have built in Silverton, because you have a practice that is years old. You are a seasoned DPC doctor. And on your website, I love how you have the phrase healthcare decidedly different. So I want to ask you, what does that particular phrase mean to you, your staff, and your patients?
So when I first learned about DPC, the first thing that kind of popped out to me was that I wanted to have a clinic where it felt like the normal dance of a normal primary care clinic. So you have someone that greets you at the door and a medical assistant that takes you in the back and takes your vitals. But I also wanted the clinic to feel like a home, and that there wasn't really a formal waiting room there. The way I phrased it in my business plan was it was the unclinic. So I want patients to feel like they can come in and just be relaxed and in a calm environment. I think we purposely want the patients to not feel so clinical, but yet it's also professional. So it's our exam rooms are just like any other normal exam room, but the experience otherwise is more like you're going to see your family.
Your clinic is called Township. So when you were developing this unclinic, and I love how you use that term, did you come up with Township as part of your name then, or did you have Township as the envisionment of your unclinic as you were developing it?
So it was all at the same time. My extended family comes from the area around Pittsburgh. And so there's lots of little townships and burgs around there. And Silverton's, it's a rural community. So there's about 12,000 people but we're close enough to Salem, which has almost a couple 100,000. And then we're less than an hour from Portland. So we're not really a suburb either, but it definitely has a kind of a township feel. And so our clinic is located in the heart of downtown. We have no parking. People just pull up right in front of the office to do COVID testing. We give everybody free quarters if they need them for the meter, and they get an hour for a quarter. And so it's definitely a township for sure. The only regret is it's very long to put that in your email address.
I hear you, but I definitely there have been longer contact email addresses, so it's awesome. Townshiphealthdpc.com. That works. Now, thank you for sharing that in terms of your geography and about how you use Township to represent your unclinic. What about your patient population? What is the makeup of the ages and the insurances that people have in your clinic?
So my patient population is probably around 60% insured and 40% uninsured. Most of the uninsured, we try to steer them towards a health share of some sort so they can have some backup. Some of them don't have any insurance, but fortunately they're healthy, and we try to keep them out of the emergency room and the urgent care so they can save money that way. I transitioned from a practice that was in town for 20 years. So I would say 60% of my patients are my older patients that some of them I've been taking care of for almost 25 years. So I know them very well. My staff is made up of my office manager, who was the office manager at the old practice when I got there when I was in 1996. And then my MA is the first MA we hired in October of 1996. All of us have been working together forever, and we know most of our patients for a long time. That really helps things.
And you and I are in the same point of care ultrasound monthly group. So I love how one time you called them your work wives, and how that's that's longer than I've been married. So that's
yeah, right. They know me very well.
That's awesome. So when you transitioned your practice, how was that transition for you, and what kind of announcement did you make for your patients who were interested in following you?
Yeah, it was. It kind of was an abrupt announcement. It was an unfortunate that I let the cat out of the bag before I was ready, I think, but it worked out just fine. Ultimately, I had about a 90-day period where I was able to not so much solicit patients, but at least tell them about direct primary care and tell them that I was going to be around. I don't even think at the beginning I knew where my office was going to be, but it was pretty much known to practice that I was leaving by the end of 2016. And then we opened in April of 2017. Basically, what I did was at that point, it was just talking about the model. It was telling people about direct primary care and the savings that they can have on out-of-pocket costs for all of their meds and labs and imaging. And that access to me was going to be far better than it was at the old practice. And then I think the big thing about people transitioning, and we talk about this a lot at the conferences, is you have to tell people, why are you leaving? What's going on? And be honest about it. Be super transparent with people. I told people, I am not happy, and I need to find a different way to practice medicine, because I feel like at the end of the day, I need to feel like I made a difference in people's lives. And when you're seeing 25 people a day and having to chart for 2 hours after you're done, it's really hard to feel like you hadn't made an impression on anybody. And that's why I had to do it. And I think people at first maybe didn't really, some people got it, but it took others a while for them to get it. And I still have people who call me. I mean, even last month, we've had people that were my patients long before, and they've just joined to practice now almost 5 years later.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. And when you look back at that first year, especially, how was your opening? Were you like Dr. Kissy Blackwell and you had 278 patients not banging down your door on day one? Or what was, as you describe that there are still some patients who are finally coming over to your practice, what was it like on day one for you?
So we had 3 months to pre-enroll people. And I'm probably one, I don't know. I don't know too many other DPC practices that actually started with staff. So I started with the office manager. So when I went to the summit in 2016 and got super excited and made a business plan and writing things down on the back of napkins and whatever through for a whole weekend of just this. I still remember it. It just gives me chills because it was like the coolest weekend of my professional career, where it was just like light bulbs were coming on for the first time in a long time and being excited about what was going to happen. And so I convinced my office manager, Janet, she was going to retire anyway. And I'm 54 and she was in her, late 50s when we left. So she's over 65 now. But she's always worked in healthcare and she's always excited about taking care of patients. And she was burning out because she was mainly working front office at the old clinic and answering phones and dealing with billing and all of the stuff that's pretty yucky, super large practice. We had 9 partners. So the phones were just ringing off the hook constantly. So she was going to retire anyway in the beginning of 2017. And I convinced her, I said, just let me convince you that this is going to be a cool way to do things. And I came back and I said, I got the thing, I've got a plan and I need you to help me with this. And at the summit, I met Dr. Julie Gunther and I called her up and said, hey, can we come visit your practice? So I bought a plane ticket for Janet and I. We both went to Boise and spent a couple of days with Julie, and she straightened us out and gave us a footprint for things and went back, and we found 1,000 square foot space with one exam room and an office and a potty. Pretty much had to do a build out. So that took probably 2.5 months to build exam rooms and things like that. During the build out, we were sitting in the construction zone with saw tables and buying furniture from Target and wherever, trying to outfit the office and spending money that I didn't have. But it was exciting. So we were able to sign up. We literally just, once we finally left the group, I left in March, she left in, I think, February or something. And I just literally started calling people and just telling them, hey, this is where I'm going to be. Tell your friends and neighbors. This is what DPC is about. And we started with, I think, 230 people pre-enrolled. And at the end of the first month, we were up to 300. And then I called my old MA and said, hey, we're growing really fast. And it's like drinking from the fire hose. We would probably need you soon if you're interested in coming to join us. And so we convinced her to come, and she gave her notice and they immediately fired her. So we hired her right away. And so we didn't have any money, but we hired her anyway. At that point, neither of us had a paycheck yet. So the MA got the first paychecks until we were on our feet and started making some money. And so by, I think, the first 6 months, it was a whirlwind. We were just onboarding as many people as possible and still doing town halls and talking to people and whatnot. But I went to the Nuts and Bolts conference in October, and by that time, I think we had 800 patients. We were supposed to stop at 600, but it got out of hand.
That's incredible. And
Yeah.
that's the last time I saw you in person was in Orlando at Nuts and Bolts.
Yeah.
So that's a crazy update, just crazy. Now, let me ask you, when you mentioned how you flew Janet out there to see Dr. Julie Gunther's practice, and you guys flew back and decided that, yes, this is what was going to happen, and the two of you were going to go into this venture together. What was it? Because for somebody who is not a physician, but for someone who, like Janet, has worked the nuts and bolts, the bones and soul of a practice by knowing it in and out, inside and out, what was it that she fell in love with? And the reason I ask this is because if there's other people out there who are talking, like Dr. Jake and Christina Much at Defiant DPC, the nurse that they work with now was the nurse that they worked with before. So for people who find themselves in a similar situation now or in the future, when they're trying to convince other people, what was it that Janet found that she loved about DPC that she was like, yep, that this retirement's not going to happen now. DPC is going to happen now.
Yeah, I think she's just passionate about the people that we take care of. She truly loves our patients, and she was missing that at the old practice because it was so busy and it was burning her out. And then the opportunity to do healthcare in a different way was exciting and a little scary. Obviously, we're going into an adventure where nobody knew that we were going to be successful. And at the time that I started, there was probably only 400 and some practices in the country. I knew it was one of those things where it was like weird based on the people that I met at the summit and who had been doing good DPC and very successful for 2, 3, 4, 5 years. Josh Umber and Julie Gunther and Amy Walsh and Vance Lassie and Jen Herder and Doug Frago, all the pioneers of DPC. And I just knew that I could grow up and be like them. I could do this. And so I convinced Janet that she could do healthcare the way it was meant to be done, and she loves her job. I think even now, I think so. She doesn't really need to work. She just loves coming to work every day.
That said, I want to ask this because there's chatter about don't leave one hell to create a new one. Has there ever been a comparable day to fee-for-service practice where she's just, this is so overwhelming, this is the time we need another provider or another physician to join the practice or another MA?
I can think of a couple of times, and mostly just pandemic related. It was the second week in March of 2020. The world was really afraid, and I could tell that things were going to shut down. Something was ominous. And so I was stressing, the town was stressing, patients, I was sending out like twice weekly updates and what's going on in the world kind of thing. And on a Sunday so that we locked down, I think on a Wednesday. And on Sunday, I sent out a group email and told all of our patients, I said, I don't know what's going to happen, but I know that they're going to shut our state down. I'm not quite sure what that's going to look like, but I want everybody to have enough medicine. We'll be able to get you medicine if you need it, but I want everybody to have a 100-day supply just in case it gets shut down for a few months, which we ultimately did. So I sent that out on a Sunday, and then the Monday, the phones blew up. And Monday and Tuesday, we filled, I don't know, some crazy 17,000 pills or something in one day. So that was, but we didn't see anybody hardly. We just had strings of refill labels. So that was a crazy day. And then we had some crazy days in August and September here, just because that was when like our fall surge for COVID this year was way worse than anything that we got last year. I think I only had 10 COVID patients total all of last year. And I probably had 100 in 3 months. And so it kind of got just a lot of people sick and a lot of people that we had to check in on. And we were doing lots of COVID testing, and we did 15 or 17 tests in one day, one Monday, and 7 or 8 positives. And we were doing all of our testing in the street. So the MAs would run out, and because we have no parking lot, so they just pull over in the yellow striped lines on the curb, and we just, then they go park until they get there, do a quick pulse ox check, and good to go. So.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. Well, thank you for answering that, because it paints a picture as to what are push point days of DPC, and you're not mentioning the angry patients who can't get in for 6 months, or like the people who are, it's my last day of my medication, the insurance won't fill it until blah blah blah. So it's interesting to hear the dichotomy there, just by the examples that you put forth.
Yeah, we don't have those weird days where we can't fit people in. I start my day with usually anywhere between 4 and 6 people, and sometimes we get to 12, and oftentimes we don't. And that doesn't mean I'm not doing a lot of telemedicine stuff or answering emails or texts or whatever. So we do a fair amount of that, but it doesn't have the same feel as the old practice. And a lot of times our follow-up visits, like, I saw a guy in the clinic today. He comes in once a week to get his weekly IM testosterone shot because he won't give it to himself. And follow-up visit for him is me yelling at him because he's in the waiting room, and he's sitting there waiting for his shot. And how you doing? Good. Medicines are good. Yeah. Doing all right. Yeah. How's life? Okay. And then he just put a note in the chart, and he had a follow-up visit. So, and that's what I do all day.
And it's not dot phrase 14-point review systems negative.
No. None of that.
The insane note bloat. Now, I want to digress a little bit, because you mentioned about your build out, you had the space that you guys found, and you were doing stuff even as construction was going. What does your clinic space look like in its finished form?
When we first took over the practice, started the practice, we had a little small waiting room that you could fit a couple of little love seats in. Janet had a desk and Sarah had a desk in the main main waiting room. Then I had my own office. There was a bathroom in between that was for not only the staff, but the patients. And then we had one exam room that had an exam table that had a procedure table in it, so I could do all my procedures. So it's totally adjustable. And then we had a little small lab in the back that we put in some shelving units, and we bought some old credenzas off of Craigslist and to fill up our all of our supplies. And then we had our pharmacy was one closet that was right next to Janet's desk. And so we had 4 or 5 shelves of meds, and then a credenza behind her that we had an alphabetical system for people that were coming to pick up. So we have they all get in sacks and go into just like the pharmacy. But then in the spring of I started in 2017, spring of 2018, I had another person join us. And at that point, we needed more space. And so as it turned out, the doc that joined us, he was the doc of his patient owned the building. And so we convinced them to sell me the building. And so the other side of the building is basically a mirror image of what I had. And it was just a shell. There were no walls or anything in it other than the exterior walls. And we bought the building and then did another big build out. So we added 2 more offices, an exam room, pharmacy, a big pharmacy room, another staff bathroom, and it had storage space in the back and a little staff kitchen. And then we busted through the wall in the back. So the kitchen goes into the lab from the other side. So it's 2,000 square feet. Basically have 3 offices, 2 exam rooms, and we doubled the size of our waiting room, which we don't really need anyway. Nobody's waiting, but it just opened up the space a little bit better.
And with regards to the pharmacy, what are the medicines that you would recommend that people stock if they are going to have an in-house pharmacy? And then what are the things that you just order as they're needed?
A lot of that depends on how many patients you have and how much money you're running through, because obviously you don't want to buy a giant stock bottle of something that's going to expire. We have a little bit of that. Fortunately, the meds are really inexpensive. So if we lose an expired thing of Prozac, then it's a couple bucks. It's not expensive. But Sarah, my MA, runs our pharmacy. So she's in charge of inventory. I would say for somebody starting out, I would do only like stock bottles in 90 or 100s and whatever the patients are coming in and needing refills. We get our meds from Endameds, so you can get meds overnight. If somebody comes in on a Monday and you can get them Tuesday afternoon, they'll have meds. So we just tell everybody, you got to give us 72 hours notice because we might need to order. And then the only things that I would stock would be like some antibiotics and not very much. So some moxicillin powder for your kiddos if you have a lot of kids, some moxicillin, some Bactrim, Cipro, that kind of stuff I'd have on hand. One of our more expensive things that we bought for the clinic was the pill counter. And so it was like $2,300 or something. But the thing gets a workout. We fill a lot of meds. Our current inventory is a little over $10,000 worth of pills, but we fill meds every day. We order meds every day from Endameds. Usually it's a couple $100 every day. And it's mostly the stuff that I use all the time. So it's statins and antidepressants and blood pressure meds, fluconazole, and a couple different kinds of creams and antibiotic drops, things like that. It's nice to have on hand, but and if you're starting out, you don't need any of that. You can get by without doing that.
Yeah, I love hearing that answer though, because everybody is different and everybody's geography is different. Like, for example, locally, we used to have a pharmacy that was open 6 days a week, and now they're only open 5 days a week and not on the weekends. Right. I had a patient the morning of Thanksgiving call and was asking about, like, how am I supposed to get a medication when the pharmacy is not open? Mm-hmm. And I was like, oh, you mean the one that I have that I can drop off at your house? Like, it's so powerful to be able to have those super commonly used medications that all of us in primary care need on a regular basis or prescribe on a regular basis. So that's great to hear. Now, I want to ask about your patient pricing, because when you had seen Dr. Gunther's practice, you opened your own. How did you develop your price point, and has it changed over time?
Yeah, the one thing that I think that I would do differently from the start would be to charge more. I think we started too low. I think we started at $60 for an adult, and that was everyone over 18. So the one thing that I didn't want to have is like all these multiple tiers of this decade you pay $70, and then next decade you pay more money or whatever. It's just, I don't know, that the one thing about DPC is just transparency and pricing, and I don't like to nickel and dime people. So I wanted to keep it simple for us and simple for them. So we started at $60 an adult, and then it was $30 for a college age kid that was living at home, and then $10 for kids. And then the max price was $140 for a family. So we had a lot of families that had 8 or 9 kids. You're taking care of 5 kids for free, basically. But fortunately, those kids don't come in very often. Most of my kids are over 5. They're not the newborn. So I'm not seeing like newborn visits. And so it wasn't that big of a deal to take care of a 5-year-old for $10. But anyway, we got into, I think it was late 2017, when I realized we were priced way too low. And so everybody knew after, I think like October of 2017, we started charging them $70 a month with a $160 max for families. And there were still $10 for kids. And then we grandfathered in everybody that signed up early for a whole year. So they had all of 2018 at the $60 price. And then I told them in 2017 or 2019, it was going to go up to $70. And so we raised our price that year. I only heard from one person, and it was one of my oldest patients. I delivered both kids through all 3 of her kids. And so she just called and she said, it's a big jump for us. And I said, we can help you out. If it's not, I can just get a price, I can do whatever, you're valuable to us. And she said, no, I just wanted to know why you needed to do that. And I told her, I explained it to her, and just very transparent, and that was it. And they're still one of my better families. I take care of probably 25 people that are extended family members of hers, and grandmas and aunts and uncles and cousins, and they're all related. But anyway, yeah. And then so when we added the nurse practitioner, we've actually increased our prices to $80 a month. And then I plan on early 2022 increasing everyone else up to, it's just the prices have gone up for everything. So that's getting more expensive to practice. And Oregon has a new small business tax. And so we have to make a little more money.
And I actually didn't know this before the interview, because I wanted to ask about how DPC is in Oregon specifically. So let's start with that small business tax. What is that small business tax, and how, in addition to raising your prices, like how have you had to pay?
I just got the notice. I'm not quite sure why it happened or what, but it's like another almost 1%. So it's significant enough. I would say practicing in Oregon is not that difficult. I think there's enough DPCs now that they know who we are and what it's all about. We have to every year run all of our website and our patient contracts and whatnot through the Department of Consumer and Business Services. And that's basically the insurance commissioner. And so they want to make sure that we're not acting like an insurance company. That's their biggest deal. I've never had a problem. I was stressed out about it at first when we put in our application, but I was open. I waited almost a year before they approved my application. And then every year we just say, yeah, nothing's changed, or we've added 2 staff people or nurse practitioner or whatever. So they're fine. So I haven't had any real challenges, I don't think, practicing in Oregon. There's a lot more DPCs now in Oregon.
Yeah.
Donna Givens and I started around the same time, and we formed a little Northwest coalition. So we had a couple of early retreats where we all got to know each other, and that was fun.
Are there non-competes in Oregon that are enforceable?
I showed my lawyer ours, and he didn't say anything that was negative, and I didn't have a problem. But I'm not aware that anybody has had any big issue. I think if you work for a big health system, then I think you might have a non-compete that might be, because then you're fighting a big corporation rather than an independent practice. When I left my practice, there were 9 providers, and the group was disbanding. 3 other providers left. Actually, 4 or 5 other providers left right after I did. One of them was leaving for family reasons, and then he moved to Michigan. And I don't know if Phil Hellman, he's a DPC doc now in outside of Detroit. And he was an old partner of ours at our old group. And he called me a year after and said, "Hey, do you think I could do this?" And I was like, "Sure." And so he's doing DPC in Michigan. And then 3 of the other partners left and bought a building, which is about 4 blocks from, and formed their own regular insurance-based practice. So they have a small group independent practice. I couldn't convince them to do DPC, but we actually partner very well. So we have some patients who or in HMO plans, or if they're in Oregon Health Plan, so the Medicaid plan, they have to have an insurance provider do their referrals if they need a specialist referral, or if they need their insurance to pay for MRIs or imaging or whatever. And so if we have somebody like that, then they can be their designated PCP and we can tag team together, and I basically take care of them. And then if I need something from them, then they go for them for a consult and see them, and then get all of their prior auths and everything taken care of through their insurance. And that's how we do there's only a few kids, but we have a couple of newborns that they come see me for their well child check, and then they go over there for their immunizations, and then they can bill their insurance for those. So it works really well.
When you mentioned OHP on your website, it says we're unable to accept new members who have OHP insurance. Is that statement coming out of this issue in Oregon where you have to have a referral specifically from someone who takes Medicaid?
It was mostly just because, unfortunately, OHP patients sometimes have a hard time finding a provider. And so when they sign up with us, it just makes it more difficult for them. Not that we want, I put that on there mostly just so we don't get into a relationship that makes it difficult for them to get care that they need. So what I would rather have them do is sign up with our partner group as an OHP patient, and then we can work the other end around. I could put that same statement to say we don't take HMO patients. It's essentially the same, because the HMO patients, they need referrals just like the OHP patients.
And in Oregon, you can still see patients even if they have the state's Medicaid.
Yeah. I can still, in general, I can order meds and we can order labs. But if it's something that needs a prior authorization, so like a CT or an MRI, then they have to go through their PCP. But I can't be a PCP because I'm not contracted with them.
Gotcha.
Yeah.
Thank you for giving more detail there. Now, I want to ask, because you're mentioning your partner practice and how you guys collaborate to take care of your community. But I want to ask, and for those listeners who don't know, you've had some serious close calls when it comes to your own health. And when people talk about how do you find coverage if you're a solo doctor, you've reached the extreme in answering that question. So I want to ask, how have you been able to take time that you needed for your own health and to heal while still being able to take care of the hundreds of patients that you take care of at Township?
Well, yeah, I think part of it is just being super transparent with your patient. So in 2019? Yeah, 2019, I was going in for a routine hip replacement and ended up having an anesthesia issue and went into asystole and had 5 minutes of CPR when they were halfway done with my hip. And so fortunately it was resuscitated and then life flighted up to Portland, and spent a couple of days without a hip. They removed it in Silverton and then replaced it a couple of days later, or actually the next night in Portland. And fortunately didn't get infected. But basically what happened after that one was I was in the hospital for not quite a week, but came home, and then we just were super, like I said, transparent with my patients. And I was able to do a lot of telemedicine at the time and recover, and patients just left me alone for 4 or 5 weeks. And so that was good. I would see somebody if they really needed to be seen, but we could still do a lot of, like I said, a lot of kind of telemedicine things. And then patients were more worried about me than they were about themselves. And then this June, I ended up getting COVID really bad and ended up in the ICU and on the ventilator for 3 days and in the hospital for 10 days. And when I went in the hospital, Janet, my office manager, called called several people. I called Dr. Neil Douglas, who's one of my great friends, who's a DPC doc here, close enough to me. And he helped organize some things in our clinic workflow. And then my old partners basically just agreed to take over my practice while I was out. And I got out of the hospital and was told in no uncertain terms by Janet that I was not to answer any emails or call people or deal with patient care issues, and set the date of return at 7th of July. So I was out for about 5 weeks and everybody was fine. Patients were great. Patients were taken care of. My old partners, they just got a cell phone that they passed around that they took calls from. They came into the clinic and saw patients during the day if they needed to be seen. And they just took care of me, took care of the practice, and our office staff took care of things, and it never missed a beat.
Just you talk about how you guys and how Silverton is a township, and legit that is a small community reaching out to help each other. So I absolutely love that. And I'm so glad that you've recovered from both of those, instances. But dang, it's again, this is why I bring up that you have reached the extremes of what do you do as a solo doctor when you need coverage. So
Yeah, it's crazy. And when we first started, when Janet and Sarah both had joined the practice and we were in that first summer, we were just working hard and whatever. And we weren't really making money yet. We were getting there, but we weren't quite. And they, broached the question. They said, "So what happens if something happens to you? What happens to us?" And so I took a $250,000 life insurance policy, and each of them get half of that if something were to happen to me. So fortunately, they didn't get to cash in twice.
I laugh, but oh my goodness, I'm so glad that they didn't either. Oh my goodness. But yeah, that's another value proposition to not that any of us would expect to get sick, but in terms of having a little bit of a perk or something to have somebody join you, it's definitely something that other people could easily do.
Sure. Yeah. I just bought a policy through the AFP.
And now I just know this because I know Dr. Neil Douglas also, but in terms of you guys both have Atlas. So how was that in terms of if there is somebody who you're sharing call with, or you're covering each other while the other is on vacation, and you have Atlas, for example, as the EMR, how was it to access each other's records within the system?
That's one thing that Neil helped out with a lot. And kudos and shout out to the team at Atlas. They basically put my old partners on as providers into my system. And so they had their own logins while they were taking care of my patients. So they were just like a provider that was in my clinic. It just, boom, they download the app and they're a provider, and the support people are awesome at Atlas. And it was pretty smooth. Makes my old partners want to be DPC docs, I can tell you that.
Yeah. I just think of like the Cerners and the teams of IT people to help do one thing, when in the DPC world, it's very different. Now, your practice you're really big in procedures, and like we are doing the same point of care ultrasound class together, but what procedures do you offer in your clinic? And do you offer procedures to both members and non-members?
Two things that I'll do for non-members are vasectomies and circumcisions. So newborn circumcisions. I think I was doing non-patient circumcisions for newborns even before I left the old practice. Some of the Salem docs know that I do that, so we get referrals every once in a while from them still. But like none of the pediatricians in Salem do circumcisions. So it's a huge hospital system, and they all just, decided together that they weren't going to do them. Basically, it was left up to the urologists, and the urologists are charging like $900, and they really don't want to do it because it's kind of gets in the way of their day. So people are happy to come, and I charge people $200, and we can get them in real quick and take care of them. And then I do vasectomies I get referrals from my old partners because they don't do them. And so we'll do vasectomies on their patients if they need them. And then as far as what I do in the clinic, we do pretty much any kind of wound repairs, lots of derm stuff. I do lipomas and IND of abscesses and sebaceous cysts and all your skin kind of basic skin cancer things. So basal cells and squamous cells, terribly big or complicated. I'll do bigger ones on, the trunk or the extremities. Little bitty ones on the face are fine. What else? Take out Nexplanons, put in IUDs, take out IUDs, lots of cryotherapy. I do cryotherapy every week for sure. Joint injections. Basic fracture management. I don't set anybody's fractures or anything like that. If it's displaced, and I send it to my brother's an ortho PA, so I have a really good relationship with his doc, and so we can get people in really quickly with local orthos. So that's a good relationship. Yeah, that's pretty much it. We have people walk in all the time with lacerations. So we take care of lots of lacerations and things.
Do you offer any services as a mobile branch of your clinic if somebody needs care at home?
So when we left the old practice, I basically told Janet, I said, I don't want to have any of the over 85 people find new doctors. And it was totally confusing to them that I wasn't going to take their Medicare insurance. So it was like, I got tired of explaining it and it just didn't work anyway. So I just said, I'll take care of you for free. We're just going to take everybody over 85 for free. So to this day, I haven't billed any of them. Still have probably, 15 or 20 of them hanging around. They're all in their well into their 90s now. And I think probably like 4 or 5 of them live in assisted living. And there's no way I make them come see me. I just go there. It's fun to go, especially during COVID, because I was probably the only one allowed in the building. And I was the only one that could visit some of these older folks. And we were locked down pretty hard in Oregon. Some of them didn't see their family members for a year and a half. And then they wouldn't allow them to eat in the dining rooms. So they were stuck in their room the whole time. And so no visitors except for the person that brought their food trays and the CNA that would come and check on them. And that was pretty much it for a year and a half. So pretty sad. But I would go visit every couple months. Just check in on them. And we'll go, if I have somebody that's sick at home that really can't make it to the clinic, I'll grab one of the MAs and we'll go do a home visit, and we can do vitals and check blood and all that kind of stuff if we need to.
Cool. And when you guys do the blood, specifically the phlebo, do you send it out to a local lab? Do you send it out to Quest or LabCorp, or what do you do?
Yeah, we have a Quest relationship, so that's great because it all integrates into Atlas. They pick up at the office every day, and all of my staff can do phlebotomy. Even Janet, she was old school, so she was trained way back in the day. And so if anybody walks in that needs fasting labs or whatever, she can take care of that, or immunizations or whatever.
Describing your DPC and about practicing specifically in the state, what is your malpractice like for covering your clinic and your care?
So I was in practice for 20 years at my old office, and I used to do OB and hospital medicine, C-sections, all that. And so I had a claims made policy and would have had to pay a pretty big tail coverage leaving the practice. And so I priced it out, and it really wasn't going to be that much difference in the premiums for getting a new policy versus keeping my old one and then not having to pay the tail. And so I just kept my old policy. I think it's around $7,200 a year or something. So it's not terrible. It's gone up a little bit in the last year, but it hasn't been too bad. It's about the same. When I was doing OB, it was a lot more than that.
Do you do any prenatal care?
It's just one of those things where it's like, it would be hard for me to do the prenatal care and give up the chance of doing the delivery. The funny thing is that I have a patient today who she's pregnant and newly pregnant. So she's about 10 weeks, and she found out that I had the butterfly ultrasound. Can we just take a look? And I'm like, okay, let's look. So that was the last patient of today. I was checking around, but she's only 10 weeks. So it's a little hard.
What else do you use your butterfly?
I use it for soft tissue stuff. I really like it for identifying abscesses and whatnot. I'll look to see what people's joints look like. If I haven't used it to guide the needle, but at least I can take a look to see where the anatomy is before I actually will do the injections. I had he was probably around, I don't know, 8, a new patient, a little scared. He had a little ganglion cyst in one of his tendons in his foot. And I knew what it was, but I showed him with the ultrasound what it was. He was pretty impressed. And then I used it a couple weeks ago. I had a gal who had a Nexplanon that was basically disappeared. And it was really hard to palpate any ends of it because it's so buried. And I've never ever put one in. I only take them out. It's not my favorite form of birth control. Anyway, so I had my new nurse practitioner and I said, I'll show you how to do these. And so we go into the room and it was a miracle that we got the thing, but it was only because of the ultrasound. It was almost like doing a vasectomy. It was pretty wild. I just was able to find it and get it to the skin surface, just like a vase almost. And, plopped it out. So wow. She did fine. Yeah. The one thing that was really helpful with this too is that I was able to find the mid portion of the Nexplanon, and I used my vasectomy clamp to clamp around the middle section of it to pull it through the skin. That's pretty slick.
Wow. Now, you mentioned that you also do IUDs. How do you get the IUDs in your clinic to be able to place them for your patients?
We can a couple different ways. One is we can have our partner group order one through their insurance, if they have insurance. And if they don't have insurance, we typically will just put them through the Bayer Patients Assistance for Modernas, and they just ship them to us. So it's fairly easy.
So over this season of the podcast, there have been people who are just starting out, people who are planning, and then people like yourself who are seasoned. And so when you are in this space of having been in practice, you're successful, you're managing hundreds of patients, you've recently added your nurse practitioner. What are some of those key business tips that you have picked up to help you continue beyond that startup phase?
I think the biggest thing is always be open for new innovations, changes. Like when my nurse practitioner found me, so I wasn't looking really. It just was the right time, and it just kind of fell into our lap, and it turns out that she's a real perfect fit for us. But I think in general, there's always churn. So there's people leaving every single month, and then we add new people every month. Fortunately, we've had at least a net balance. And now with the nurse practitioner coming, I think we've added, 25 new people this month. Well, actually, that's November, not December. But yeah, you always got to keep putting out content on Facebook, keep talking to people in the community. It's all word of mouth, really, for us. So always talking to your patients and trying to let them know that you're available to see their family and friends. I think the pandemic has helped DPC in general. At least it has for us. I'm one of the only people in town that's independent. I can have a opportunity to have a meaningful discussion on vaccines and just what's going on in the world without having to worry about my job being in jeopardy because of what I say.
Mm-hmm. Gotcha. Now, I want to ask, because you are part of the DPC Alliance, and just this past fall, you and Dr. Neil Douglas were hosting the DPC Mastermind in Hood River. So can you tell people, other people have shared on the podcast before their experience as attendees at a DPC Alliance Mastermind, but what is the experience like from somebody who is organizing it, and who are these masterminds made for?
So Dr. Neil and I have actually done 2 of them now. So I did one last year in September 2020 in July, which was pretty incredible considering all of the COVID restrictions. So it was one of the only in-person things that was available. And we did that at Silverton in my clinic. And then this year we did it at his clinic up at Hood River, which is about an hour and a half from here. The fun part of it is there's a general structure to the masterminds. And obviously people come for the how do I get started, the simple frequently asked question things. But you can also tailor make it to the individual group. So the group that we had in Hood River this year, I think there were between 12 and 15 attendees. And then we had a couple of other DPCA board members that came to help out and be part of the group. So we had Dr. Kissy Blackwell and Jeff Davenport and Amy Walsh, and somebody else came out too, blanking. But anyway, it was fun because we can, have some one-on-ones with people we had some people who were completely contemplative that are still in their fee-for-service job and are wanting to find out more because they don't really know a whole lot. And then you've got people who have been open for a while. I mean, they just want a little bit more encouragement or tips or whatever. And networking, that's a great place to network with other docs. People are still amazed at how helpful other doctors are to getting people started in DPC. That was one of the biggest things for me. Is I spent 20 years of my career hardly ever talking to the other doctors in town because we never collaborated on anything unless it was in the doctor's lounge. And then once we all stopped doing hospital medicine, we never saw anybody anymore. And so unless it was a social event, but for DPC, I mean, we communicate almost on a daily basis, sharing cases, answering questions, mentoring people. It's a big collaborative group. It's fun.
Excellent. And I can't agree with you more on that. It's just, it is such a different world when you talk to a DPC centered physician versus somebody who is in fee for service. It's incredible how that you can feel that palpable feel instantly when you talk to somebody who totally gets DPC.
Totally. Yeah. You're not one of the inmates. Yeah.
What's been your best day in DPC?
The best day in DPC, I would say just opening the doors that first day, just feeling free and we're starting to build something exciting, and we're building a business and building a practice, and patients were excited. And so that's probably the best day. Every day is a great day though. There's hardly any bad days in DPC. I've only had one that was like super hard, and that was just because of the things were compounded. It was the day of our first anniversary of being open that I had a patient the week before clearly had a probable ovarian cancer just on exam, and by talking with her and ordered some labs, and so her labs came back and her CT scan came back about 5 minutes before I walked into a brand new patient who was an old patient of mine I hadn't seen in 3 or 4 years, that came in because she had neglected her breast cancer, that she bilateral breast cancer that basically she had 2 giant tumors on both sides and was metastatic. And so had to tell her she had cancer. And then that literally happened within 5 minutes of each other. So that was a pretty awful day.
Yeah, it's never easy to break that bad news, but back to back, that's crazy. But I'm assuming though, that because of the relationship that you've built with both of those patients, that you were the best person to be in that.
Oh yeah, for sure. Yeah, no, even in when there's bad things happening, it's a lot easier to be just a real support to them rather than, I'm just dumping this news on you and I got 15 more people to see. I think it's a blessing to be able to take care of people that way.
There might be listeners that can really relate to that, because I know for sure that I've been in that situation where it's like, haven't had the time to look at the pathology before I have to go into the room, and didn't expect that. And then, now I only have, so many minutes before the next procedures coming in, and it takes a lot of the humanity that we're capable of out of a visit when you have to break bad news. So I hear you when that was your worst day, but for the listeners, like that was your worst day, and not because you couldn't do something because you were charting for hours and hours after work So it's a very different worst day. When it comes to your scheduling, do you have any tips or tricks about how you arrange your schedule or block your schedule?
I've always found that you have to arrange it around your life. And that's a nice thing about DPC is if you've got a family event, a ball game that you want to make for your kids, or you want to get out early because you're going out to dinner or there's a play or whatever that evening, then you just schedule it out. In my schedule, I just block out the last 2 hours, or I block out an hour and a half every day for lunch, mostly because that's when I do my admin stuff, pay the bills and whatnot. Sometimes it gets filled up with patients, but for the most part, it's free. I'm the medical director for a drug and alcohol rehab center. I still do admin things for them. So that's a half a day on Thursday. So Thursday mornings, I'm not in the office, and Friday afternoons, I'm not in the office. And the staff is there, but they can answer the phone and direct anything towards me. But this morning I woke up and that was a 9 o'clock patient canceled. There was nobody until 10 o'clock. So I just put no patients from 8:30 to 10 o'clock so I could just go in and do some admin stuff. And so that way the staff know not to fill it. So it works out pretty well. I don't allow my patients to schedule their own appointments. They have to call the office. And that's one thing I've found, because otherwise what happens is you have one person at 8:30 and the other person at 4:30. And it doesn't make for a normal day. That way we can direct them on how it works best for our schedule.
I'm the same way in terms of, I always think about how patients think that they only have one problem and it's only going to take 15 minutes. And then they come and they see you and they're like, since I have you, I'm going to drop 4 issues on you. And it's definitely not a 15-minute visit. So I'm totally on board with that myself. Yeah. And I just love that. You design your schedule around your life. This is why that's
why you're doing this.
Yep.
And you have to be available for your patients, but that doesn't mean that you'll always have to be available for your patient. People call all the time and they're like, I want 9:30 on Wednesday. 9:30 on Wednesday, I'm not going to be in the office. So let's try to figure out an alternative that will work better. And our staff is really good at managing all that.
Now, what resources would you recommend to others, not only starting out, but also for those people who are in their second, third year and they're wanting to grow, not just maintain, but they're wanting to grow their practice?
I think the last couple of years have been a little odd just because we haven't really had that many in-person events for DPC. I really think that there's the networking with other DPC doctors is invaluable because everybody's got a different take on things. Everybody's seen things and done things. And it's super helpful to be able to pick up a phone or send an email or send a text to one of your DPC colleagues to answer any questions. I would say as far as recommendations in the new year, hopefully, we're going to have more in-person events. I know the DPC Summit is going to be in person this year in Kansas City. That's going to be in July. That will be the first big DPC event that we've had in 2 years. I would totally encourage people to be there, even if you're open. There's going to be a lot of DPC 101 content, but also DPC 201 content and maybe even 301 content, more like learning how to do new procedures, how do you learn something new that you can add value to your clinic. I think my relationship with the DPCA has been awesome, and I'm one of the advisory board members and founding members. I truly believe that giving back to the movement is important, and that I saved my career by doing DPC. So many lives that we can get on the lifeboat. That's my goal. So being part of the DPCA is good. I think there's local regional kind of DPC chapters that people are getting together. The Pacific Northwest has one. I know the Northeast states and the Midwest states have one. So look for those things to network. And then there's lots of good books now. If people are looking for books, Doug Frago has several. Shane Purcell has a good one. Dr. Julie Gunther has a good one. So it's lots of good information out there. And these are people who are pioneers.
Just to echo what you said with regards to the DPC Summit, dpcsummit.org is where you can find more information as it comes out for next year. But July 15th through 17th is when it's going to be in Kansas City, Missouri. So definitely it's already on my calendar. I'm super, super looking forward to being there in person. Super excited, hopefully, to see you and so many other people there. So on that note, I want to ask if others are wanting to reach out to you, what is the best way to find you after this podcast?
So the best way to get me is through my email. It's Dr. Rob at townshiphealthdpc.com, DROB. So I check my email all the time. So, and don't hesitate to look us up on the website too, townshiphealthdpc.com, and the telephone number's there. Always happy to talk with anybody. I mentor people all the time. I had one of our mastermind attendees called me up and said, "Hey, can we come visit?" So she brought her husband last week, and we spent the afternoon at my clinic and showed her through the day-to-day and the workflows, and answered a bunch more questions. Love talking to visitors. So does Janet. So she loves to help people.
Awesome. Thank you so much for joining us today.
All right. Thank you very much. It was a pleasure.
Next week, look forward to hearing my story, coming to you from Arnold, California. Please visit mydpcstory.com, where you can partake in our listener survey and help me craft next season with your suggestions for topics, guests, and more. And another huge thank you to our sponsors. Hypnos is a physician-led, physician-managed group of board-certified sleep physicians looking out for your patient's sleep. Exclusively for DPC patients, the home sleep apnea testing is just $99. That's $50 off the regular price. Visit gethypnos.com for more. That's GETHYPNOS.com. Thanks also to the Laceration course for their support. If you want to learn and improve management of lacerations in your practice, check out thelacerationcourse.com for more. My DPC Story listeners can use the code MYDPC75 at checkout for $75 off registration. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, including DPC swag, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, happy holidays and see you soon. This is Marielle Conception.